Hi, everyone. This is Qasser Mukhtar with the U.S. Centers for Disease Control and Prevention, bringing you greetings from Atlanta, Georgia. On behalf of my colleagues from the CDC, TEFINET, and the CDC Foundation, it is my pleasure to welcome you to today's webinar. We thank you for your enthusiasm and active participation. Please go ahead and introduce yourself in the chat box. Please write your questions in the Q&A tab. And as usual, we'll send you the webinar recording link and slides by next week. We will also share a link to the written questions and answers from this session. And we really appreciate your engagement in the quiz and evaluation. Your feedback is important to us. Next, please. So today we are excited to bring you a new three-part series on interpretation of study findings. This series will run from July to September. Please note the dates for the upcoming sessions. And just a reminder that those who attend all three sessions will qualify for a certificate of completion. Next slide, please. Today, Professor Lackland, Welton, and Weber will discuss EPI measures and risk estimates, describe frequently used EPI measures, and the applications of different risk measures. With that, I turn it over to our speakers. Thanks, Dan.
Thank you. And thank you everyone for joining us today and continuing with this kind of a new series, new piece that we do have. This is the first one we're talking about the interpretation of study findings. That's our session, thinking about epidemiologic measures and risk estimates. Kind of a topic that is a little bit less exciting, but such an important topic, and we see it all the way through. Our usual disclaimer that we often bring through, that that we're responsible, the speakers are responsible for the content, not in there. Our learning objectives today, we'll talk about the different types of epidemiologic measures, and we'll talk about the application of these measures to thinking about risk and how we assess. And I know that all of you have already used these measures, you've already got it, but you've also seen, not you, but you've seen others abuse these measures. You've seen misinterpretations of this. And so what we'd like is, as you would start to kind of think, how do you describe your work using some of these measures, the condition that you're interested in, or conditions or diseases, applications, how do you describe it using these epidemiologic measures? And then also, as you read other works that you see, how are they doing it properly? Are they describing the content? Are they describing the risk in an appropriate manner? So application for yourself with writing a paper, doing a report, interpretation of others' works. Kind of starting out, what better person to do would be able to quote Albert Einstein, and thinking about here where he says, not everything that counts can be counted, not everything that can be counted actually counts, but what gets measured gets done. And so this is where we take these indicators and what can we do to actually apply something. As we think about this measurement, I think this is kind of a nice thing. We basically have a phenomenon here, don't we? And so what the measurement does is kind of captures the phenomenon. It describes the situation that we have. And we're going to do a few examples as we go through. And again, I know that each of you have used these measures. You use them every day, I suspect. The thing about that classification, basically, we base it on what is the objective of the classification. So if you're talking about stroke, how do you describe the impact of stroke? How do you describe the condition that you have? Thinking about the conceptual model, understanding what the phenomenon is. How do you describe a particular condition. You have a great passion for it. That's great. How do you describe it for others to say, yes, this is really a bad condition? Why is it bad? How is it bad? Describing that part. All of this, though, is based on the availability of data. And as we talk about a thing, what do we have, how to put it together? So this is the kind of direction that we'll take a little bit today, using things that you, again, are very, very familiar with. The first one that comes out is the measures of mortality, rates and ratios. This is one we use all the time, all the way through. And so we'll go through stuff, and I know many of you, most of you have already done all of this. Why do we use mortality rates to begin with at all? Well, it's basically the cornerstone in formulating health plans and policies that prevent or reduce premature mortality or improve our quality of life. It's what we immediately think about. It's what most all of us are trying to do, is to necessarily, we're not going to prevent total mortality, but prevent premature mortality and disability. Doing this with death data. That's what we all do. Advantages for mortality data, boy, everybody's got it. For the most part, all throughout the world and globally. It's not, of course, 100% pure and everything, but in general, basically, if an individual dies, there is a death certificate associated with that individual, and these formulate databases. So this is data that's available to all of us globally, and bringing in, here's the death certificate. One piece started in here and say, yeah, but the cause of death varies. All these pieces, absolutely, absolutely, and we'll talk about that later. But for the most part, if a person has died, there is a death certificate associated with that, and that's kind of globally, so that you can easily calculate a mortality rate. Basically, for the most part, there's some uniformity there in the content and the format among the different states and countries that we have. That this is, again, uniformity. Death certificate. So what I see in one country, very similar to what we see in another with regards to the format and the content, which is mostly death. The challenges, though, is data quality. There we are. The accuracy of, there's a cause of death there. Is that really there? There's there's no autopsy data, most often no autopsy data, other types of characteristics. Is this the actual cause of death? Issues that we have as a limitation, things you already know. And then also the biases that are in that data interpretation. What might be labeled as a stroke in one country, it's general type of people, but maybe there's another type of stroke, a little bit different, and thinking about the biases in different countries and different places. You see this oftentimes in cancer mortality, where the cause of death kind of varies, again based on more of the interpretation and who is certifying the death. Another piece that's in there is a limitation. Who certifies it? Sometimes a clinician, sometimes a coroner, sometimes another person can certify. But nonetheless, if there is a death certificate. So here's the things I think that just kind of a reminder of these pieces. Mortality rates, just simply because of the databases. Mortality data are generally more available than morbidity. The other places that mortality data is readily available, so that if someone were offered a challenge to get something together in short order, I suspect almost all of you would be able to do that in a relatively quick manner, these kind of calculation considerations. If we look at fatality, it reflects a lot of different factors. So mortality rates sometimes are often not a good surrogate for incidence rates, which is what all of us like to know, right? We like to know the incidence rates and those pieces that we have. Lots of times, that we'll see that the mortality rates don't equalize that. You know that. Lots of other people, though, don't know that, and they get them confused, and we'll talk more about that too. And one of the rates that are here, the death certificate cause of death is not always accurate, and sometimes when it is there, it's not useful. It might be changing something and building in different types of categories.
In fact, Dan, that comes up all the time. And having spent many years of my life in a very busy general hospital, we would often not be sure what the cause of death was. We knew we had a seriously ill person. It wasn't a surprise that they had died, but what should we actually attribute the death to? And everyone, or I shouldn't say everyone, but so many doctors and other officials who might have to sign the death certificate say, well, one thing we did know is that the heart stopped beating. And so they will choose a heart attack or a heart-related event as the cause of death, even though this patient might have had long-standing cancer and it was near the end of the illness or some other major problem. And I know that when we've done clinical trials and we've tried to identify, did this person die from cardiovascular causes, or was it a cardiovascular death, or was it something else? It's always been difficult to be certain. And so I'm glad you brought this up. We really need to be very careful, particularly if we're going to be doing a clinical trial, of setting up very clear definitions of what has caused the death, and make sure that everyone who's part of the trial or a survey works by the same rules.
Yes, Dr. Weber, thank you for these comments, because it is very, very confusing. Even, I'll give you one recent example. We were doing just holding the death certificate in our hands and looking through these, and there's something called the underlying cause of death, which is where you've had multiple causes of death and I'll give you a very, very specific example. There's an older person in a nursing home who has end-stage renal disease as the primary cause of death, and it might be due to hypertension and diabetes. Also on there is written down COVID. So we just did a little quick check to see how many times did COVID come up and become the cause of death. And you say, oh, this person died of COVID. And it was quite frequently. And that's that kind of bias that you put in here, that COVID, and COVID was certainly perhaps a factor. But this is an older person with end-stage renal disease, and the actual what caused the demise was end-stage renal disease. And so it's formulating that question. What is the question you're trying to answer, and in consideration of the limitations of the mortality data? Great points.
And Dan, if I could add, on the flip
Please.
side, total mortality or all-cause mortality is exceedingly helpful.
Yes.
It's one of those things in almost every country,
Paul, I think you froze up on us.
Yeah.
Yeah, I think it might be just Paul. I think the point, though, is extremely valuable. We can all talk about our mortality rates by age, by these others, and we'll have some further examples of that as we move forward. Great point by Dr. Welton. This is the calculation. I'm going to go quickly. This is directly what Dr. Welton was bringing in. The crude mortality rate, the great value in this, basically the number of deaths divided by the population at risk during a specific time period. Easily calculated, almost in every report throughout the world. The annual mortality rates. Oh, you see this everywhere. Each of you, I imagine many of you have been already involved in even determining these rates. simple mortality rate with great value. And I can do this crude mortality rate by age, by gender, whatever I would like to see. Easy measure that has great value to you to describe the risk in your particular population. There's also the case fatality rate, really kind of a proportion, but basically the proportion of cases who die of a specific condition. It's when we get into the morbidity side of it and incidence side, we can kind of describe, but again, another value in a mortality using death data and using mortality data. Here are the considerations that you do think about. It sounds easy. Here's mortality rates. But what are you thinking about? So if I showed the overall mortality rate and my big interest was endometrial cancer, well, everybody, the whole population is not going to be to the endometrial cancer. So maybe I'm thinking, maybe I need to focus in on women. Prostate cancer, maybe I need to focus in on men. If I'm looking at mortality, I have a death certificate with this cause. I want to think about who is in that population, who is in that denominator, so that my rate makes a big difference. And so if you think about it, I want to describe endometrial cancer. And if I'm using my entire population, it makes it look a little bit diminished. And so I want to use just women. On the other hand, here's breast cancer. Okay, how do I think about breast cancer? Do I think about the whole population? Men can have breast cancer too. It's not as common, but it still can happen. So very importantly, consider that denominator when we're doing those calculations and building this piece forward as you're doing your calculating your rates. Other critical factors: age, maybe immunity if you're looking at different parts, genetically susceptibility if it's that kind of stuff, and you have access to this kind of data, thinking about that you've got deaths, but thinking about that population, thinking about the denominator that you want to have in the rates. And I know that you know these kinds of things. Further issues, thinking about time, thinking about how many years you're going to be kind of collecting, and you're going to be excellent doing this. And you're kind of asking this question: are 10 people followed for 10 years the same as 100 people followed for 1 year? Thinking about these pieces, thinking about the aging of a cohort, the population, thinking about secular changes, just things to think about. There are no parts that you will do as you think about a mortality rate, where you're interpreting that mortality rate or you're going to calculate that mortality rate.
Dan, could you just, we often use the term secular changes, by which we generally mean things that are going on that are not necessarily directly related to the disease, but are things that are happening in the community. It could be the climate is changing, or things like that are happening. And is there a good definition of secular changes? Because they can be an important factor. Just as you've already pointed out, we can get distracted from the real issues because other things are going on in the community.
I think you, Dr. Weber, I thought you had a pretty good definition right there with some of the examples. It's things that are that would kind of affect it. Aging is one of the things. You have an aging population that goes on. The weather that you've described, immigration, people that have come into a population, that have gone out of a population, specific conditions that you would have for a particular project. Perhaps we see this sometimes. A group has a specific cultural or perhaps religious practices that would affect the outcomes and make them a little bit different than what you would see in another type of condition. I think this is an important piece, and I think you're bringing it up. Great. We can actually, let me take a look at this and add that maybe into our chats and questions that we would have for the future. What are some really good secular changes where we can actually show and define when we're considering mortality data.
One of them, Dan, that goes across all countries and all regions is not even a physiologic change. It's a financial issue.
Oh,
For instance,
great.
if a government suddenly says, whatever this condition is, we're now going to be paying for treatment and making it more available to people. And so that affects the event rate or the death rate or whatever endpoint we're looking at. That also would come under the heading of a secular change.
Yes.
And so many
Yes.
things are going on that we have to be alert to in trying to understand our findings.
Exactly. And individuals in that country are the best suited to say, hey, we've got some unusual situation, or we have this situation, and describe it. I think this is great discussion and a great note. This is just kind of this. It's so important, almost as we've been discussing here too, also thinking about the units and making that very, very clear in the interpretations. And this is the equations that you're calculating and bringing in that piece, because I see this all the time, and I suspect almost all of us do, where someone has misinterpreted simply because the unit is there. They'll quote some rate, and then in reality, it's not, doesn't provide the clarity such that you could actually determine what exactly is being brought through. For the sake of time, I know most everybody is involved in this, and this is where it kind of leads into the importance of standardization. The most common one, of course, is age adjustments of different rates. We can also stratify by those different groups, things I know that you're familiar with, and we can that have already been addressed. It's just kind of a reminder that you want to think about these different pieces, thinking about weighted averages, things like that you'll have with a methodological type of an approach. But I bring it up here. It's just kind of bringing in that interpretation. Are these crude rates? Are these age-adjusted rates? If they're age-adjusted, are they adjusted with the same manner in the different pieces? And so just things to kind of consider as we interpret what we see. Mortality rates, again, as Dr. Welton said in the beginning, that first one, just the mortality rates. People have died. Valuable piece. Where you trust the information, the cause of death can be added, and age, race, and gender are important considerations as well as you kind of work your way through the mortality rates. So I just want to do kind of this one example. So here's a critical question. Are there gender differences in cancer mortality? And just do these kind of quickly as kind of a fun right up in here. So this is a little data from the United States showing the value of looking at just something. This is all cancer deaths. We can talk about the description with even all of the biases. But using that, this is looking at deaths from 1930 to 2000. And this is not about cancer. This is not about anything. This is just some data. So one of the pieces that you do look, if you look at something like cancer data, you do see a fairly large disparity between men and women. And so men and women are different. And so if I look at the different patterns and I look at at cancer deaths and looking at these aspects, I see in the 1930s in the United States, cancer deaths were greater among women. Okay. And then long about 1950, you saw a shift where men had this piece right up in here. So if I just said, just looking at that really quickly and look at you as an expert, and I say, what do you think is happening in 1950? Some of us would say we're starting to see the impact of cigarette smoking, where cigarette smoking that was begun in the 1930s, more common among men, we're starting to see cancers associated with cigarette smoking. and it's overtaking, and it's been maintained throughout where men. This is just one of other possibilities, but this is the one that you kind of come in and get your head thinking. So can I do any more with this? Well, I can. If I have a database where it's a little bit good, I can now look at the actual types of cancer that we see. I see this for men and look to see lung cancer has gone up to where it's tremendously for men. Lung cancer is the greatest cause of cancer, of cancer mortality that we have. Very, very significant. You see the grand trends. You see stomach cancer actually coming down, pancreatic, other cancers pretty much there. And but really it's that kind of lung cancer. So you suspect, and there are other ways to evaluate that we don't have time today, but you can see very quickly, just looking at mortality rate, I can find some data that's valuable to me to look and make some considerations as to where a focus might be, or I can develop some hypotheses. And you can see that this might be one of the reasons that we have. As opposed, I can do the same thing with women and notice that the pattern that I saw began in the 40s and then into the 50s and into the 60s. It all began early on, and I see that upwards trend early on, much earlier than I see in the women, where I do see that now lung cancer has overtaken the other types of cancers with regards to mortality. But I'm seeing that beginning happened here in the 1960s, 20 years earlier for men than I was seeing these trends in lung cancer. If we look at some of the other patterns that individuals have done, they're starting to kind of see that if we look at patterns of cigarette smoking, you see it kind of replicates pretty much the same. And I can look at the other cancers and see what types of things have been happening. And I suspect each of you can do it. You may say, well, what's happened with uterine cancer? It's gone down so significantly. What might be some of the patterns? We might say this might be a clinical practice, or where we're doing hysterectomies and other types of pap smears, et cetera, this kind of stuff, just to kind of bring these kinds of this kind of information out. How we can kind of use this type of data. Asking this other, again, kind of, does cancer mortality vary by race, sex groups? And just another way that we can look at, and this is examples, this is not about cancer, this is not about this, it's just kind of showing ways that we can use some examples of using mortality data to get some comparisons. This is looking at looking at pretty much cancer mortality, that total part that we do see. And you can see there are gender differences almost for each race group. Very quickly, I can identify higher risk groups that I might want to investigate further. Just some pieces. Very quickly, we can all do it. So if we look at, again, these the epidemiological measures of mortality, kind of looking at these rates and ratios that fall into this category. And I know that many of you are familiar with this, and the other pieces that we carry through. Now we're looking at morbidity. Here is the top of our group. What's the prevalence of a particular condition? And I know that you've done this. Got these definitions down, and that's good. And we've talked about this previously in other groups. Knowing what the prevalence is, bringing this through it, this is basically a count, the number of people with a disease or a condition. Notice we're not talking about new cases. We're talking about, does a person have the disease? It can be a proportion, the proportion of the people in a population with a particular disease. Again, prevalence is often expressed as a proportion specified, this condition, and we'll give some examples in care poll. Here's an example that we had. Again, bringing this forward. The number of existing conditions that we have and the number of new cases that we have divided by the population at risk. So if I were interested in stroke and I wanted the prevalence of stroke, I would take Have you ever had a stroke? You will be in the numerator. And the new cases that come along, they also are added to the new cases. So it's everything, existing and new cases. So thinking about it, what is your question? What are you trying to do? Will prevalence answer your question? Prevalence is a little easier to calculate, as we'll talk about. Does that answer your question, or do you need something else? Do you need an incidence rate? The assessment that you can kind of look at is, we look at prevalence, we're looking about the impact of the population. Some of us do some work. I do some regional work, and you look at stroke prevalence all around the country, and you can identify, particularly in an area that I live, where the stroke prevalence is so much higher than it is in other parts of the country. It's so much that we kind of label our area called the stroke belt that's here. Imagine you have situations in your particular country where prevalence is an important factor. So prevalence is impacting my population a little bit higher than it is in some others. So prevalence is a useful tool for me. If though I want to look at trends, I probably want to look at incidence, and that's going to be the new cases that we'll also talk about. So here is looking at incidence, prevalence, and here's just kind of as an example. So here is a remote community of 101,000 people. They have one hospital. So this patient census, I mean, basically beds are there, is 1,000 beds. The admissions seem to be on a steady state of basically 500 admissions per week. Okay, so the prevalence that we would have would be 1,000. We're talking about a steady state, looking at a 2-week population. So we're looking at 1,000 patients in the in the hospital, divided by the total population, 101,000 people, right up in here, giving me a prevalence rate of 9.9 per thousand population. Almost 10 people per thousand population. The prevalence would be considered hospitalized, whatever the condition was. The incidence, on the other hand, 500 people per week. So now my incidence is 500 divided by 1,000. You say, well, what happened to the other 1,000? They already had the condition. They can't be a new case if they've already had the condition. So I eliminate them from my denominator, and I come back in here. And so now I have an incidence rate of 5 per 100,000, per thousand, per week. Here's my calculation. That would be very useful if Dr. Weber and Dr. Welton are in that hospital and they want to know how many people can they expect to see? What does their workforce need to be in order to meet the needs and to bring the population? They need to have incidence. Incidence, a little more complicated, isn't it, when we're kind of calculating? So a little bit more. Our duration is 2 weeks. Just one example, and we're going to do a little bit more of this as well. So you're thinking, what do I wish to see? So if we look at, again, the relationship of incidence and prevalence under certain conditions, the prevalence odds, again, often are the incidence by the duration, and the prevalence is kind of an indicator of the incidence by the duration, just a little more that we kind of bring it through. Now, let's talk about the incidence rates and this piece. This is the rate of new cases or events over a specified time for the population at risk. In medicine, the incidence is the newly identified cases of a disease or condition per population at risk over a specified time. New cases. So if you're thinking about new cases, are you able to identify new cases? And how are you going to do that as kind of thinking in this important piece? So we'll do a little bit more. Forgive me for always doing stroke, but just a little bit more. So if I looked at an example of incidence would be, in this case, 795,000 new cases of stroke each year. So people that had not had a stroke have a stroke. And this is what we saw in 2023. The incidence now, and the incidence is 795,000 new strokes. The population of the United States is 335 million people per se, and the time frame is this one piece in 2023. Thus, the 2023 incidence would be basically calculating down into is basically 2.36 new strokes per thousand population. This is, I can evaluate this into a trend. If I'm looking at my program, am I seeing a downward trend in the number of new cases? If we do this, as we're talked about, I can do this by race, I can do this by age group, providing a very valuable bit of information that in some groups it's coming down, some groups it's maybe going up, but this provides me a lot of information of how am I doing, kind of an evaluation of what a trend is. And this is what you'll see in almost all the reports too, in addition to the mortality rates. As you get this kind of information, this can provide you a very, very valuable and useful tool that we can bring in.
And this is, of course, a very nice example because stroke is usually diagnosed reasonably accurately. There are clear clinical findings, a clear history, and then radiologic and other diagnostic tests to confirm that a person has had a stroke. It's more difficult, though, isn't it, if we have conditions that can be important, such as what we went through recently, the COVID pandemic, because some people were clearly diagnosed because they had symptoms sufficient for them to get tested, and in some cases sufficient for them to be admitted to hospital. But many people had COVID but did not get diagnosed. How do we deal with that? How do we adjust, particularly for things like infectious diseases? How do we adjust for not being able to really get a proper handle on incidence?
Right. Dr. Weber, that's the major question for all of us. And so we have to, at some point, you have to make that decision. I don't have a database that's accurate enough for me to calculate and report this. So now I need to work on the database. There are surrogates, and if you believe that surrogate and it meets your point, if you're, for example, if you're saying, I want to know what the trend is in strokes for young adults, meaning under 50 years of age, and I've got this kind of information, I know it's not, I don't have those good diagnostics. I don't have brain images. I don't have the things that I really need to make the diagnosis solid. I might want to say, what I'm going to do is I'm only going to use hospitalized cases where I'm assuming that there's a little bit more validity to the diagnosis than just maybe a self-report or something like that. I'm going back to my question, seeing, is this definition or diagnosis of a new case, does it meet my particular needs? And I'm going to work it from that standpoint. And sometimes I'm going to have to say, I just don't really have a good diagnosis here, and a self-report or something is just really not going to work without the proper diagnostics. It also comes in where I see, and I know most everybody here sees, particularly with something like incidence, where one group has a pretty good definition. They've got something really kind of solid, and they're calculating new cases based on this solid diagnostic criteria. Another group is saying, well, I'm doing it just simply based on self-report. And where we're seeing a comparison between these two groups where one has solid diagnostics, another does not. And that can lead into a lot of misinterpretations and misunderstandings, as you well know. So this is you're bringing up such an important, critical consideration. So as I look at the incidence rate, I want to look to say, how did they determine what was a new case? What was their definition of a new case?
Can you use, for want of a better term, sort of post hoc testing? For instance, if I want to know the incidence of COVID, let's stay with that for the moment.
Yes.
Would I have been entitled just to take samples of people in the population, do a blood test, look for antibodies, which would tell me whether or not someone, with reasonable reliability, whether or not someone had already had COVID? They mightn't have even known they had COVID, but
Sure.
it would be a fairly objective measure. Can that be used as a means of estimating incidence rates?
It can be, but it brings in that new case. So I've got the antibodies to that. If the tests were really good, but I'm not sure the tests are quite that good where I can say, I can define it. I had COVID last week versus I had COVID a year ago versus I had COVID 2 years ago. And you see this sometimes. This can be done in all kinds of things. There are some tests to do to test you whether you've been you smoke cigarettes, because some people just don't tell the truth. They don't say they smoke it. So you can take it. There's saliva test or blood test that you can do to determine if a person is a cigarette smoker. It's really good within an hour. It's okay within 6 hours. A little bit all right at 12. Picks up some people at 2 or 3 days, other people it doesn't pick up. It depends on your washout. So the point is so good. Some of the post questions, I mean, it's post test, that's that quantity. If you want to pinpoint that the new cases and the new and the new incidents. One more to kind of stay on this important topic. A big question is hypertension. What is the incidence of high blood pressure? So is it when I'm first diagnosed, and as we well know, some people have been hypertensive for years, but they're diagnosed here. Am I new at that point, or is that what I want to calculate as a new case, or do I want to try to come up with a better estimate? And I'm only going to do people perhaps that have serial blood pressures that you would see kind of in a study where I can say, this is when your blood pressure truly went to the hypertension state. This is such a critical piece, and different people do it different ways.
Yes. No, it's very challenging, but important.
Yes.
And of course, conditions that are based on measurements of continuous variables, and hypertension and diabetes are perhaps the two most common and important ones we think of in that sense. It all depends on not only the frequency of testing and looking for these conditions, but also definitions. So one group of experts may say, well, we think you're only hypertensive if your blood pressure is more than 140. Another group of experts may say, no, if you're more than 130, we're going to call you hypertensive. Others may have other definitions. And so, again, we have to be very, very aware of criteria for diagnoses, and also at the point you made, the hidden diagnoses, people who've been hypertensive for years, but it's only discovered now. But so we don't know when it all began, but it's very likely if someone walks into my office with a blood pressure of 160 over 110, that they were probably hypertensive 5 or 6 years ago.
Correct.
And have been going along in this very risky situation without being properly diagnosed and dealt with. So again, it makes sometimes the incidence calculations a little arbitrary.
It makes it extremely difficult. You described that extremely well, and it's a dilemma. And what we do with some of these, and we see this all the time, a common question in the hypertension world: has a health professional ever told you that you have high blood pressure? And we say yes. And so that puts that person in the hypertension category. And you can kind of just see that. So those definitions, I think the point here, whether it's stroke or it's hypertension or it's diabetes, really look very greatly. What is that definition that we're using? Thinking again, also with incidents that we've just got through and how we describe it. Incidence is looking at, again, kind of the frequency and building this piece in. The incidence, again, is specified sometimes in person years. And again, methodological issues, we can address this as you like these kinds of things addressed. But you look at these kinds of descriptions of incidents. There may be 324 million people in the United States for a measured year. So strokes could be specified as having an incidence of 2.5 strokes per 1,000 person years. Okay, kind of giving you something. So if I were going to do a comparison or I was going to look at trends, I want to see this estimate over time. This means that there would be an average of 2.5 strokes if we watch 1,000 people in the United States for 1 year. This is very valuable to Dr. Weber and to Dr. Welton, but it's only valuable if they trust this estimate and they understand what the definition is going to be. But it's a valuable thing. It's kind of letting you know what we would be expecting. What can I do to prevent these occurrences? A little bit more looking at now at incidence, taking again our cancer rate. So now let's bring in, we've talked about mortality. We've looked at different trends right up in here. So now we look at cancer incidence. And this is going to go right to Dr. Weber's point. So I'm looking at, I have a system. This is cancer registry data. So I have a good database that I somewhat trust, I guess. And I'm looking at now cancer incidence, new cases, people that did not have cancer, were diagnosed with cancer. Stages are an issue. So as Dr. Weber was saying, if you're diagnosed at stage 4 cancer, you didn't go from no cancer to stage 4 cancer. You went through stage 1, 2, 3. You just weren't diagnosed. And so this brings in a kind of an interesting piece with regards to the conditions that he was referring to and when they're diagnosed. But let's look at prostate cancer. Notice that when we talked about mortality, if I was only looking at mortality data, prostate cancer didn't stand out to you. Lung cancer did, prostate cancer didn't. But if I look at incidence, I look at this and I'm seeing that up until about 1987, I started kind of seeing prostate cancer was kind of on a parallel with lung cancer incidence and these pieces that we're bringing in. What may have happened, just to kind of go kind of quickly, you started to have a campaign and an early diagnosis, basically a blood test for PSA that was kind of brought in. When you started seeing the blood test and you started seeing the examination for prostate cancer, now I'm picking up all of those cases. And to Dr. Weber's point, this is a peak. I'm picking up stage 1, stage 2, stage 3, stage 4. All of those cancers I'm building in. So a major campaign for building up kind of screening and diagnostics. This is a common thing that you see when you have a new test that's come out, a new diagnosis. You start to kind of see a peak in what appears to be the incidence. Notice it comes back down. So now what you're doing is you're seeing kind of a leveling off of the test is there. And so now you're looking at more of the of stage 1 prostate cancers that you're seeing, which is also the reason you're picking up the cancer at an early stage and you're not seeing it lead into mortality. This is not about cancer. This is not about this, but it's how you look at you look at the prevalence and the incidence rates and come up with some type of a conclusion. This is just one example of many other conditions. You see the same thing with COVID and many of the other conditions, and we can also apply it to other groups. If we looked at this as this is kind of similar. This is that same interpretation of incidents that we've been having, and kind of this is the same calculation and determination we'll go through. You want to estimate the population time. And this is important. In this case, whether you calculate it or don't calculate it, not related, but it's something that you want to have in your mind as you interpret a incidence rate. You want to think, is the population at risk the same? The population eligible to become a case and to be counted as one. So if an individual has already had the disease, has already had the condition, they really can't be a new case. They're an old case. So they would not fit into either they would not fit into the denominator. In this case, the population declines as the case occurs. And again, you can't be a new case if you've previously had the disease. So your denominator should be going down over time. The limitation that you see in the person time limitation is that person time assumes that the probability of the disease during the study period is constant. So that 10 persons followed for 1 year equals 1 person followed for 10 years. More often than not, this assumption is not there as you look at the different conditions. If you look at all the things that Dr. Weber brought up in the beginning, conditions that affect these rates, and they can affect new cases. It could be seasonal. It could be other factors that are coming in, ages, and an environmental piece, or a government changing the economic indicators, whatever. Something affects it. Things aren't typically constant. Something affects what those new cases are going to be. COVID is a wonderful example that you have. So again, as you're calculating this, thinking about things aren't constant, and then you make that interpretation. And again, how you interpret and how you look at these different pieces. This is just an example of what we're talking about in here. So in the perfect world, you look at a person and they get the disease and follow it through. Sometimes you see a case, the person dies. Okay, so now but you're looking at the time frame, might be there, other pieces. Here's a person that wasn't identified until later in the study, so that we have no information about them in this beginning. And this is just giving you, this is the real world. We assume this case number 1 is what is there. That's what the assumption is, that everybody was identified at one condition, and then they were followed for the entire study period and they died at the end. This just isn't this in the way, so it complicates a little bit of the timing in these pieces forward. The incidence proportion, again, we can kind of do this. We want to calculate in this case, the cumulative incidence, and this is the number of new cases over the population at risk. And again, the idea that we put in here, the incidence proportion is often called the cumulative incidence, where you're bringing in the incidence over time and calculating that pattern over a certain number of months. Again, if we bring in here the incidence rate just one more time, if we bring it through and we're looking at person years, and let me just go back to this just real quickly of how you calculate. So this is a person that's followed for a year period. So this is a person that died after 1 year. So this would be a death after 12 months. Here's a person that died, looks like at about 3 months. Okay, so their denominator would be 3 months. This is somebody else that also died after 3 months. And you would put that together, and that allows you to do this cumulative incidence, and then it allows you to then calculate into the person years. And going back to our stroke example, where we can make this type of determination, 2.5 strokes. If we watch 1,000 people for 1 year, there would be 2.5 strokes, and it was determined from that data of different following rates. Want to bring this one up just as one more indicator. of what we see when we consider disability and age-adjusted life years. This is called a DALY. Probably seen this as a very common that's used by the World Health Organization and many people that do global work, because it gives you a comparator. This represents the loss of equivalent of one year of full health. So this is a person that has it. These DALYs for a disease or a health condition basically are the sum of the years of life lost due to either a premature mortality, they died early, or the years lived with a disability. So I can look at this again, age adjusted, what have I lost? Disability loss. So I could have died, but I could also be disabled and not be able to work, and et cetera. Looking at this due to the prevalent cases of a condition. Now we're looking at prevalent conditions. And so now we're looking, did a stroke affect me later on? Did COVID, long COVID, did it affect me later on? Does blood pressure affect me later on and remove me from being able to have productive years of life lost? Just one more indicator that you'll see that you can kind of see and allow different kind of comparisons and a description of a particular population. This is giving you one that I suspect that many of you have seen in the past of how this could actually be used. And you see this interpretation all the time. What conditions, in particular non-communicable diseases, what conditions greatly affect the possibility make the burden of disease? And that's how this was particularly labeled. What conditions are there? And then you see the conditions that we talk about that you already knew: cardiovascular disease, premature mortality, conditions like a stroke, prevent someone from being productive. It gives you that summation where you can really see the life years that have been lost. Cancer right there, neonatal orders, and you see kind of this. There's just one type of ranking where you can kind of get the impression, so that if you were one that wanted to promote cardiovascular disease prevention, like I do, this would be an indicator that I would want to use to make that statement that, boy, we really need to have a program. We need to have policies that address cardiovascular disease. And I could use this in many senses with existing data that I could get in a very short period of time. The cumulative incidence, again, is the probability of developing disease over a stated period of time. Again, one more calculation. I know this is repetition, but it's just, we've presented a lot of stuff and discussed a lot of stuff, and just want to bring back in that cumulative incidence, the number of new cases over a period of time divided by the number of persons developing disease. Again, another example of the cumulative incidence that could be used. Here's 21,000 women continuously enrolled in a health care plan and undergoing at least 2 mammography screens during this 1998 to 2002. 2,258 have a positive second screen. To Dr. Weber's point, this is the group. This is a person that clinically they have had 2 positive mammogram screenings, and we're going to call this a cumulative incidence. We're going to call this breast cancer. So the cumulative incidence is 2,258. Here's my number that had a positive second screen, a positive diagnosis, if you will, over the 21,011. These are the women that were not previously, did not have an indicator of breast cancer previously. So they were kind of breast cancer free, if you would. And so I put that together and I calculate this cumulative incidence of 10.8%. It'd be this cumulative incidence part that we have. Simple calculation, but I gotta have those 2 screenings. You gotta have something that we can kind of trust. This brings back in to the point that we've been kind of making, looking at incidence and now looking at prevalence. The numerator in incidence is the new cases developing that with the capability of developing disease. The numerator for the prevalence is all the cases of the disease. New cases, prevalence, any case, regardless of when they were diagnosed, not to be a new case. The denominator is all susceptible people without the disease at the start. Prevalence a little bit easier. All persons examined or assessed, the whole population there. Now, if I want to do incidence, I'm going to need to do a cohort study, people I can follow so that I have the date that they developed the disease. Prevalence, I can do a cross-sectional study. Just saying, they got the disease, great. And then we're going to kind of calculate it. Certainly much easier for me to do a prevalence study than it is for me to do an incidence study. The odds ratios that you calculate, relative risks that you calculated, things that you kind of remember. If it's close to 1, minimal association. If it's greater than 1, a greater association. I'm doing foods here as just as an example. Less than 1 is protective, and the magnitude of the association is what you would consider. So just one more piece. In a case control study, you don't know in a case control study, you don't know the incidence, and this is why you would go to one of the other methodologies. And I'm just mentioning this in this capacity. If you don't know the incidence, you want to look at a case control study. Again, you don't calculate now the relative risk because you don't have the incidence. Again, case control studies, the proportion of cases that were exposed and the proportion of cases that were not exposed. And there's some calculations for that we can talk about. Case control study, you cannot calculate the relative risk. This is where you want to have in your mind as you read a study and you're seeing if the people that are presenting the report, or if you read a misinterpretation, someone is saying, oh, the relative risk, and I got this from a case control study, meaning I did not get it from a cohort study. This would be a situation. And again, you have to start. It's because having started with the cases and controls rather than starting with the exposed and following people that you would do with a cohort study. Again, odds ratio is a measure of the association between the exposure and the disease in a case control study. And again, you're asking the question here. Again, we talked about the question, what are the odds that a case was exposed? Because you're starting with the cases. What are the odds that a control was exposed? And the odds you calculate with this calculation and calculate the odds ratios. So here's just one example of a risk assessment doing a food outbreak. This is cyclosporiasis in New Jersey. It doesn't really matter. And again, this is about 8 cases. So doing a very quick case control study, I have the cases, people that ate a specific food. I calculate and I come up with an odds ratio of 32.7. What does that mean? And it basically means that the odds of eating raspberries among the people with the disease, with the case, are 33 times higher than the controls. 33 is clearly greater than 1. So basically saying eating the raspberries could be a factor for the cyclosporiasis in this particular outbreak, just to give you that type of an example. Other types of studies that we do have that we bring in, case series, again, looking at the number of cases, you don't have any controls, you can use case series and use some of the mortality data. Cohort studies are going to allow you to calculate an incidence, and it's going to allow you to look at the relative risk. Case control studies, you don't do the incidence, but you look at the prevalence. You don't have that piece, and you calculate an odds ratio. This is kind of building in this same type of conditions. Case series, people with the disease, small number of cases. Cohort studies, well-defined groups, easily defined. You calculate a relative risk. In case control studies, you calculate the odds ratio. What's your question? Formulate the question, make sure that it's the appropriate measures and the interpretations. The advantages of cohort studies, we've been saying, it allows us to calculate incidence as well as absolute risk. It risks the exposures and the disease. The exposures are assessed without bias because you're following and building that piece in, and you're able to calculate the relative risk. The disadvantage is it costs a lot of money. It's very, very time consuming to do a cohort study. It's inefficient, as many subjects needed will never ever develop the disease, which is why you don't do a cohort study on a rare disease. You'll follow them, particularly cancer. If you follow them for a long time, they never develop the disease. And only parameters measured can be actually assessed, and things change in building it forward. Comparing a cohort study and a case control study. Cohort study is not rare diseases. You want to do something that's common. Strokes could be used. Heart disease that we've already shown are there. It's prospective, it's very expensive and time consuming. It's retrospective if you have very good records, and it's valid, can be affected by the losses to follow-up. People get tired of being followed or you lose them. Case control study, on the other hand, is not rare exposures, but it is rare diseases. It's great for that. Incidence rates cannot be calculated with a case control study, and there is a selection bias and recall bias because you're basing things on the past and getting them to carry forward. But been again a useful tool, this kind of stuff. Okay, it's for case controls, it's basically less expensive rare diseases that we've been talking about. So I want to close up here, and let's walk through one more example that we've been doing, and then we'll get to our poll questions. If we're thinking about, here's a statement that's made: is the COVID-19 pandemic basically the same as the Spanish 1918 flu, such that it can be addressed in the same manner? Okay, so here's the question that you have. And unless it's there, you don't want to spend a long time. It's a very simple question. And can we use some of the data that we have available already and answer this question, or at least address this question? So here's a statement that follows through and brings in here. COVID is officially America's deadliest pandemic, as U.S. fatalities surpass the 1918 flu estimates. That's a nice statement. It's in a good publication. And here's people reading this, and they're thinking, boy, this is really bad. I want to read it. You want to read it. And we all want to read it. And let's take a look to see what we can actually do very quickly and see if this is a valid statement. I'm sitting here telling people strokes are bad. Let's see what we have. Well, the first thing is to look at just what the two organisms are. We comparing apples and oranges? Is it fair to compare these two groups? Well, for the virologists in the group, or the people that are into the virology, there's a little bit of a difference in the viral RNA between these two culprits of viruses that we do have. You would make that kind of decision. But the second one is real important for our incidence and other data that we have. The incubation period for the 1918 influenza virus is 1 to 4 days. 1 to 4 days. Very, very short. Kind of building it up in here. Boy, you're contagious after a short period. The incubation period after COVID was 4 to 14 days. Much longer period of time. Bigger type of impact and this makes a big difference. The next one, though, is what really gets you what you're comparing. There are few asymptomatic cases with regards to the 1918 pandemic. My understanding, clearly I wasn't there, but reading the reports, if you had the flu, you knew you had it. Everybody had symptoms. For COVID, as Dr. Weber alluded to earlier, nearly 1 out of every 5 are asymptomatic cases. So you don't know, you're building it in here, how am I able to determine incidence if I don't know? So a little bit of a diagnostic piece that's there. The second piece is to kind of bring these in. So now I'm going to take these rates based on this earlier piece, and I'm going to do some of the kind of comparisons. Let's go back to that statement. Worst thing that we've had, worst pandemic ever. So there's, if we look at the numbers that we see for COVID-19, there's 318 million cases globally. This is, of course, going up. 500 million cases for pandemic. Some people say we'll eventually get there, that these will equal off. But right now, as far as number of cases, a little bit more in the pandemic. The case fatality rate globally, about 1.7% for COVID, and but greater than 2.5%. So more people are dying. A little bit there that we kind of compare. We have this number of cases in the U.S. We don't know what it is for the 1918 pandemic. The case fatality rates in the U.S., 1.4%, 2.5%. Again, this is not about COVID. It's about using these data to answer a particular question. The death rate in the population in the U.S., 1.4%. The death rate from the pandemic was earlier. So this pandemic is a little bit higher as you're reading the 1918 pandemic as far as impact and building this forward. This brings in the final, this is my final piece of this. And again, I know probably many of you know this much better than I do. But here's just looking at that comparison, addressing these issues. And this is what that statement was based on. The number of deaths in the US based on COVID, much higher than the Spanish deaths. But the denominator that was a lot greater for COVID-19 than it was during the Spanish flu, just the magnitude of the population increasing. So now I'd probably like to see a rate, right? The number of cases is 104 cases, clearly more, 25 million cases than in here. Survival rates were better for COVID than they were for the Spanish flu, but actually still pretty good, right? Number of cases, people surviving. Actually not too bad, at least on the for the US. If we look at these same calculations, we see different pieces. Certainly the population of the world has greatly increased. And now this is where that rate kind of makes such a great difference. 99% survival globally for COVID, 90% for the Spanish flu. So maybe there's a little bit of a difference right there that might be making a difference. This is just showing you one more time. If we look at case fatality rates for COVID, and again, kind of building in those pieces, the case fatality rates were right there in the beginning of the pandemic in this piece. Again, how we use these rates, we were thinking, is there constants, this part, just getting you kind of thinking of these examples. Again, this is not about COVID and the content that they are. So remember in our summary here, the rates require a numerator and denominator. The prevalence is all people with the disease and conditions in the population. The incidence is new cases among the susceptible population. And one more to our pieces here for our Congress that's coming up. Our newsletter, we ask you to please take a look at it. We're actually having a raters content in each of the newsletters. The questions and answers, which we welcome very greatly from anybody, please send us the questions. We will provide a written response and post it here to the on the World Hypertension League website. And again, our Congress, we would like to emphasize at the Congress that'll be coming up in February in India in 2025. Encourage each of you to think about maybe coming. We will have a writer's workshop on each of the mornings of the 3 days designed for early career individuals interested in writing and different types of components. We will have a component of this where you would be able to bring some of your work, and it would be, we can review and discuss with some of the experts in the field, an opportunity to review. So I would encourage you to maybe think about this aspect, and certainly invite any and all to attend. Also, you may want to think about this as a place to maybe a Congress that you would like to submit your abstracts. and be a part of kind of the presentation part. And with that, I thank you, and I will stop sharing there.
Well, thank you, Dan. That was outstanding.
And I think we've got some poll questions.
Thank you. Thank you, professors, for this wonderful and outstanding presentation. Measures and risk estimates are very important in our work, and yet they're often misunderstood and misinterpreted. And we greatly appreciate how clearly you explain these measures and their applications with examples. So thank you again. Everyone, please type the questions into the Q&A chat box. And before we open the floor for questions, depending on whether we have time or not, let's go through a few poll questions together. And I'm going to invite Kesser to read the poll question. Thanks,
Thank
Kesser.
you. Thank you, Sushma. And really excited to see that there are at least 1,000 people joining us today. So, and also appreciated seeing comments, Dan, and answers to your questions as you were lecturing. So really appreciate the interactivity. Now for the poll questions, the first case is that the Minister of Health has just learned about World Hypertension Day and wants to make a statement for media such as television and newspaper. He or she asks you for data that would have an impact and need this information within 2 weeks. So here are your options. What I'm going to do is give you 30 seconds to read, and then you can type your response, whether it's A, B, C, or D, in the chat box.
The responses have started coming in.
As we're moving, for this is first off, this group makes me so happy. I almost have tears in my eyes of joy. This is a real situation. I imagine many of you come into this kind of scenario. The Minister of Health, the division director, the department chair, they want to make a statement, and we see this with World Hypertension Day all the time. So they want to be the person knowledge, and they come to you and they say, well, give me a good statement to build forward. Y'all are just getting this absolutely right. This might be an opportunity, I think, to obtain stroke mortality rates for the population, and just basically with a statement. Again, this is for a statement for World Hypertension Day. This isn't determining how many beds we need in a hospital or determining what types of strategies that we have, just simply making a statement. So you could take something like stroke mortality data for the population, emphasize that hypertension is a major risk factor for this leading cause of death. This is how many people are dying in our population this year from stroke mortality, and I think it might be in that case. So I would think that that number A would be that piece. The others are kind of real though, right? So the real purists, they say, no, you want to make a real statement, it's got to be based on incidents, hypertension incidents. That's the only way that we can do it. That being the case as well, we're going to have a 5-year, we have to wait 5 years, develop a cohort study, and determine what the hypertension incidence in the population. That's a great thing. but probably impractical for just simply, you're just asking to make a comment for the statement for World Hypertension Day, encouraging people, bringing in kind of awareness. And so that would be a part that you would have. So it's a, but we all know purists. We all work with some purists that would say B. I think this would make the Minister of Health in this case very upset. You're too busy for such nonsense and focus on the basic science of blood pressure. We all know somebody that's like that too. Like I'm doing real science. I don't have time for this shenanigans. I just put that in there because I don't think that's just something that I've heard. And then there's the person that would say, we don't have any data in this country. We've only got some of this mortality data, but we've got some really good data from the UK. Let's use that. Well, that's not about your country. That's not about your population. So I think in this particular case, I would go with response A. And I think this is one, again, with the World Hypertension theme, maybe each of you might participate in World Hypertension Day next year with that type of information. Thank you.
Excellent. Moving on to the second scenario. Clinician has compiled statistics from various reports, but the reports are a mix of incident and prevalence cases of diabetes. So the clinician is asking you for your help to resolve the issue, and your responses could be any one from A to D. Again, I'll give you about 30 seconds to read, and then start typing your responses in the chat box. And I'm consistently seeing B, Dan.
Okay, me too. Again, I highly enthused about this. Is a great group, and I suspect that many of you have had these kinds of situations. Unfortunately, it kind of goes to what Dr. Weber was saying early on. This happens a lot of times. Go ahead and mix the groups and just say, well, they all have diabetes, and we'll just kind of put it in there. But it gives you such a different, because the denominator is so different. And by just kind of putting them together, it gives you a misrepresentation. You don't know how many were incidence cases. You don't know how many were prevalent cases. You just don't know that type of that type of information. Y'all are spot on, and I thank you very much for this. B is the right way to do it. You just basically report incidence and prevalence separately as you're able to determine, because the implications, as we've discussed, are so different for each of those. This is just this. I only put C in there, and some people think I made that up. I didn't. I saw somebody do this one time. They just put everything. You don't need to recalculate it. They just ranked these rates, and the highest ones were the prevalence, and the lowest ones were no pattern to it at all. You get a little bit upset with this, because when you put this kind of number out, it's a number that you can't trust. So the clinician can't trust some of these kind of calculations. And if they can't trust it this time, what about the next calculation? What about the next calculation, and on down? And you get to a place where it can't it can't be addressed. D is, I probably did just put in there, you got to address it, right? This is our job, is to bring it in here, but to do it properly.
Thank you. Moving on to the next one. An investigator has identified an area of the region where the crude mortality rate for end-stage renal disease is 5 times higher than the rest of the region. She's asking for your advice on the next steps and assessment. And again, your choices are A to D. You can isolate the area immediately, as this is a clear indicator of an environmental exposure. A mortality rate of 5 times greater is unheard of, and there must be something wrong with her math. You can say, let's conduct additional group analysis, including age, to determine if such factors might be playing a role in the increased risk, or you can refer all to the nephrologist immediately.
And again, this is a wonderful group. And I can tell this is a seasoned group, but I also appreciate how serious you are with this, with these indications. And I think this is putting in, I think, the proper piece. Otherwise, you get some of those difficult things right up in here. You could see a scenario where somebody'd say, oh, this is an environment, we've not seen end-stage renal disease rates this high. Let's isolate it off in here. Something is causing this. And not the appropriate reaction, in my opinion. Just assuming that the math is wrong, this is basically saying, oh no, that's just wrong. It can't be. There have been so many scenarios, and I know Dr. Weber has seen this too, where you've seen an area that, boy, that really looks strange, and it's real, and it's something that needs to be kind of addressed. And so this could be the place. I think the proper piece is C, as most of all of you put in there very appropriately and nicely. Do some subgroup analysis, thinking particularly about age and other factors that might be playing a role that can be addressed, and say, yes, the rate is 5 times higher, but here's a reason. Perhaps it's an older population, any of the other factors that could be associated with there, and to kind of explain it and then emphasize the importance of doing it. I think that would be a lot of people to refer to the nephrologist. Certainly eventually we will want to get to that point, but I think referring the whole population to the nephrologist, I think, would be perhaps an extreme here, but I think you got it right. And these are scenarios where some of them might sound a little bit silly. I think most of you have experienced this, that some of this is real.
Thank you very much. And that concludes our poll questions. Over to you, Sushma. Sushma?
Sorry, I was on mute. Thank you, everyone, for participating in the poll questions. And in the meantime, we would like to appreciate if you could fill out the evaluation form using the link in the chat box or the QR code you see on the screen. Your feedback is important to us, and we value your suggestions. And please keep those questions coming. We won't have time to go through them today, but as Professor Lackland mentioned, the written answers to your questions will be posted on the WHL website and also on the TAFNet website. So please visit those websites to receive the answers to your questions. And please note that part 2 of this 3-part webinar series is scheduled for August 15th. This session will focus on sensitivity and specificity. Please mark your calendar and register. And also a quick reminder that you must attend all 3 parts of this webinar series live to receive a certificate of participation. There have been many requests for slides and recordings, and we will make sure to share these materials with everyone who attended and registered for this session. And we look forward to your participation in the rest of our series. And this is all we have for today. We thank the WHL faculty and everyone who participated in today's session. Please complete the evaluation form if you have not done so. And we look forward to seeing you next month. We appreciate your time and attendance today. Have a wonderful rest of the day. Thank you, and bye, everyone. Thank you, Dan and Michael.
Thank you.
Great as always.
Yeah, that went very nicely, Dan. You really had some great examples, and that just flowed very, very quickly, very smoothly. That was terrific.
Thank you, Michael, and I appreciate the comment. We just want, this group is going to know what mortality rates are, and incidents. Just trying to get them to think of what the question is and what the what the situation is, what they're trying to do, and in one sense, don't force that. Don't force a square peg in a round hole, or and vice versa. Making sure that you're able to address it. The other one is just, I've just come across this a little bit with World Hypertension Day, but for all these other types of campaigns, I've actually heard it. I was asked, someone asked, they were going to do a Go Red for women, and somebody said, well, could you talk about some statistics? And they got some statistics from way far away, had nothing to do with the local population. And in a place like South Carolina, boy, that one is just easy. I mean, that's just one you can just say, look at the stroke map. Here we are. This is why this is important. So bring it through. That's just one of our thoughts.
Oh, in fact, you identified, Dan. I was part of something that the International Society of Hypertension started a few years ago, called May Measurement Month.
Right.
And all over the world, people were setting up little